Hi, everyone. We'll get started in just a minute. We'll get started in just a minute. Thanks, everybody. Okay, it is 1:02, so we'll go ahead and get started. And hopefully on this beautiful spring day, we can give you a little moment back on the other end of this 3-hour session together. Thank you so much for your time today. I'm Alex Caldwell for folks on the phone who are calling in. I'm the director of the Center for Healthcare Affordability. I want to thank our Healthcare Affordability Advisory Task Force members for being here in person. And we have a couple also calling in from online. Our co-chair is not here. One of our co-chairs is not here today, and I just want to wish her a happy birthday. That's not actually the reason she's out, but Sheila Cascaden it is her birthday, and so in her absence, we just wanted to recognize that. I just learned that this morning, but she is doing some important work on behalf of children in Minnesota, basically. So she's not able to be here today. We do have our other co-chair, Matt Anderson. Thank you for joining, and thank you for your continued attention on this issue of healthcare affordability and carrying out the legislative mandate of the Center for Healthcare Affordability. I also just want to recognize that since this group got back together, this group hasn't been together since February. Lots has happened. We are 4 weeks away from the end of our legislative session in Minnesota, for example. Lots of activity that this group has been, a part of and working on, even, from the sidelines as well as kind of in the Capitol itself. And so I just want to acknowledge that. And there's just a lot of alignment I see as well between some of the work that's happening there on administrative spending, for example, increasing transparency in who owns healthcare entities. There's a lot of alignment in what's happening there and what this group is doing. And you're moving towards making some initial recommendations to MDH. And so you're not doing that in a vacuum. And I just want to acknowledge that and just recognize the fact that even though all of that is happening, what I want to encourage this group to really do today and in continuing its work is orienting the fact that the Center for Healthcare Affordability and its advisory task force functions will continue in perpetuity. And so like I'd ask you all to just be thinking about there are many different things that we could be paying attention to at this moment. I think about our Hennepin healthcare, HCMC. I think about all of the hospital sustainability challenges that we're facing right now, the Rural Health Transformation Program. There's lots out there happening. We are following all of that as well. You all are working on it. And this group, I think, can uniquely look a little beyond that and just offer some sort of course setting for Minnesota. So that's really what today's about. Thank you for being here and continuing to pay attention to this really important issue. I'm going to, let's see, hopefully move this ahead. We have a full discussion planned for you today, and we want to do a couple of things with you. One is the Provider and Payer Advisory Task Force, of which we have 2 members in person today. Thank you, Joel and Gita, for joining us in the back. And we have some folks online as well that I haven't gone through that list yet as to who's here, but thank you for your continued attention. That group has come together since February, and so we have some input to offer to you as to what that group is reacting, what their reactions are and how they want to sort of offer some groundwork for you all to take forward. We'll also introduce to you some factors, what we're calling factors for consideration, and how they might inform the development of some initial recommendations to MDH on where to pursue additional research and policy development to improve affordability for Minnesotans seeking healthcare. We'll talk more about what those are and like how we're using them and how they might be used even in the future. And then we're going to spend most of the time today prioritizing. So in your pre-reads, member of the public listening in, you'll see on the screen a portion of what the group sees on their printouts and in their pre-reads, a synthesized list of the conversations you have had to date on potential areas for research and policy development. So that's where we're going to spend a lot of time today. It's like actually providing some input on how to potentially sequence and prioritize the many different issues that this group can be studying and working on, because it won't be a single issue that will sort of solve some of these problems. So to do that, we'll start with some of the Provider Payer Advisory Task Force feedback and just a reiteration as to where we are in this process, a reminder of why we're sort of talking about these topics and prioritizing. And then we're going to jump into those factors for consideration and some prioritization. We're going to ask you to actually take your cell phone out and like use a little QR code on the screen and do some voting. We'll be able to share back with you some of that data live. Reminder that the slides will be available on the center's website. This meeting is being recorded. Folks that are in the back are visible on the screen, so I just invite you, if you don't want to be on the screen, we can certainly move some more chairs up here. I'm sorry, we've taken them up, but we'll put a couple more up here if people don't want to be in the video. Closed captioning is available if you would like to use that if you're online. Bathrooms are available down at the end of the hallway. Please remain on mute when you're not speaking. And of course, task force members online, we are eager to hear from you, so we'll turn to you and invite you to chime in. Please do email us at health.affordability@state.mn.us with any questions. We have people standing by to help. So where we are going next. So I wanted to reiterate why are we talking about these topical areas? Where did these come from? Where are they going next? And remind the group where you've been. So this is this image you've seen before. You started looking at this back in October of last year, and we've been calling this the roadmap. And what this is intended to illustrate is this first round of multiple rounds that these task forces will continue to go through to say, let's understand what are the challenges here in Minnesota with respect to healthcare affordability. Let's look at the data, look at what other states are trying, look at what are the options for Minnesota, prioritize, narrow, and really come up with some implementation ready specific recommendations. And so where are we now? You have started in this first phase of selecting on, I think it's page 11, those 4 big buckets of potential areas of recommendation. We'll review some of that as part of the discussion of the Provider Payer Advisory Task Force input. But right now, you're at a place where you've provided, if you remember last time, walking around 60 plus sticky notes around the table, around the room. We have taken those. we have taken your discussion and input to date. We've taken the provider payer advisory task force input, and we've looked around at what other states are trying, what might be the opportunities here in Minnesota. And we've provided to you a set of options. And that is what is on your table 1 and 2 printout and in your pre-read. And then we will walk through some of those today. Our goal here is for this group to be able to provide some initial preliminary directional recommendations. These are not necessarily policy recommendations yet, right? But these are directional recommendations to MDH as of about June of this year. So I just want to remind this group of that's why we're doing this, is where we've been. This is not the last time that this cycle will occur, right? So this list that we put together is an initial synthesis. We'll talk more about sort of what went into that thinking and what's up for discussion today. But really the goal here is for you all to be able to say, we can't do everything at once. These are maybe the 3, 4, 5, I don't know what the right number is. We need to talk about that. But these are the places where we would like MDH to really help staff up and do some technical work to help us figure out what might need to be true in Minnesota to pursue some of these recommendations. With that, I want to just open up and see what questions are coming up. And Matt and Sheila have both been thinking with us in the interim between these meetings to just really do the synthesis. Think about what is most helpful at this moment, given that these are not yet policy recommendations, but they are sort of the first step to get to even a place where we can get more specific. So I wanted to invite some conversation, and I wonder if, Matt, do you want to add anything more to that before opening up for discussion?
Some places to put resources or put attention to try to get some early solve health reform the system as a whole. Oh my goodness. Oh my. Okay. Not to necessarily, do global reform or some massive, but where do we want to start directing attention and particularly for the center and MDH, some of the expertise, so that we can learn more about these areas of interest to develop more specific recommendations or to develop some more policy ideas down the road. So just trying to put that in the where we are today in context of this not being final recommendations or someone saying, I don't know how you'd put this into a legislative bill. That's sort of more down the road still. Does that make sense? Helpful?
That's helpful. Yeah. I want to invite questions. What reactions? Is this lining up with your expectations? What questions are coming up for you? Marie, how'd you know? And sorry, can we just make sure that everyone's clear? Are people okay to use these mics? Okay.
Did they work?
That one's working.
Okay.
Okay, thank you for letting us know. Yeah, we'll figure that out.
So this is maybe a placeholder just for a broader discussion, but questions about the timeline makes me think about this really interesting moment we find ourselves in with having possibly a new commissioner, definitely a new governor, and definitely a new legislature next year. So it puts us in an interesting, that's just the environment we find ourselves in, which also then begs the question kind of our role in that health policy environment. Not to hash it out right now, but at some point it'll become important as well, the timing considerations.
Thanks, Marie.
I think this is Sheila Maroney. My comment might be an add-on to Marie's, which is also in light of all of the policy activity going on right now in the legislature, how does what we do complement that, compete with that, undermine that, support that, and who's leading whom in the long run, in the short run and in the long run?
Thank you. Yeah, Sheila and Maria, I think both of your points are well taken, and that what I see as this group being uniquely positioned to do is to offer some initial guidance, some steering as to this is what we know so far. These are things that we don't know. This is where there is a tension, at the legislative, in the legislature, but also even across other states, right? I think about, looking at private equity and corporate entrance to the marketplace. That's sort of a newer field, I would say, than 5-10 years ago. And so, like, we have some more learning in other states that maybe is a unique place that this group can weigh in, as opposed to some other challenges that are really long-standing challenges that maybe this group wants to sort of put to the side for a second and say, we're going to start here. So the sequencing, I think, is that kind of guidance will be really helpful to get from this group. All right. With that, I'm going to go ahead to the Provider and Payer Advisory Task Force input and just share out a little bit of what we heard from that group. That group met in March, and they had 3 things to do. One, they reviewed some of the survey results that they had provided that this group got to review. So they said, these are some reactions to the Healthcare Affordability Advisory Task Force's work to date. Here's some groundwork we would lay for them if they are talking about value-based payment as a way of improving affordability in Minnesota and designing benefit plans, designing health plans in a way that's streamlined, that steers consumers towards high-value care. They offered some insight into your conversations. And so we'll share a little bit of that today. And I want to invite some conversation from this group and questions, because in May, this group will come back together and have not a dissimilar discussion to the one we're having today about those 2 topic areas. So we'll kind of look at those 4 topic areas again and just kind of see how those recommendations are starting to emerge. The group also, so the group really spent some time talking about value-based payment and insurance benefit design. And so again, these are these 4 topics that this group has prioritized back in January of this year, December and January. And you've really been talking so far mostly about the top 2. So when you walked around the room and you put the sticky notes on the wall, those were topics, research questions, policy areas. Those were areas of interest related to high and variable prices, mostly in the commercial market, and they were related to what we're calling non-value added spending. So administrative complexity, administrative spending that may not be adding value for consumers. Prior authorization is one of those areas that the group has discussed as to a potential area of reform, as well as intermediaries and investor-related spending, like new entrants into the healthcare system and different owners of healthcare entities that may not provide value to consumers. The Provider and Payer Advisory Task Force helped lay the groundwork for these other 2 topics that this group has identified. And so these are the ones that we'll be coming back to in May. They are not reflected on the list of topics in your packets. And so that's why we'll really be focusing on those top 2, because you've really had a time to look at those. You haven't yet gotten to look so much in depth at the second 2. So we will be doing that next time. So what did they say? When we asked them, is one area for improving healthcare affordability in Minnesota by changing the way or influencing the way insurance benefit plans are designed? And they basically said, maybe. So what we're talking about here is health plans, covered benefits, member cost sharing, access rules, all of those things we know affect whether a consumer pursues care, whether they find it affordable, whether there are equity implications to whether they can access that care. And what they said was there is potential in influencing benefit design, especially increasing use of primary care and incentivizing primary care use, steering patients to lower cost settings. And that came up in this group's discussion on selecting this topic area, as well as creating incentives to choose higher value care. At the same time, the group did feel that there were some significant limitations to, like, how would we influence those plans at the state level. And they named the fact that there's really significant complexity already in our health plan designs. And so by introducing this additional sort of layer, maybe we're not actually improving things. Maybe there's actually an additional level of complexity that's just going to confuse patients. It's going to confuse providers. And maybe we're actually going to see shifts to other parts of of the market. So there were some real sort of challenges that the group raised in whether or not there's real opportunity here. And at the same time, we have seen other states pursue these kinds of designs to improve affordability. When we asked the same question about value-based payment and to what extent might Minnesota shift their current mostly fee-for-service payment model to a value-based model, could we see improvements in healthcare affordability? They basically said, yes, there probably is more of a there in this bucket. So again, this is really, we're talking about shifting towards rewarding quality and cost control rather than paying per unit. And the group said that there's likely an opportunity here to make care more affordable by supporting prevention, care coordination, upstream intervention. There's also more flexibility in how care is delivered. They did note that there has been a slower adoption of these types of models in Minnesota. And they named a number of challenges related to that. And so, for example, lack of timely information at the point of care, you're not getting timely performance measurement information related to that quality payment. There's primary care staffing shortages, implementation capacity for a rural system, for example. These are risk-based arrangements. If you already are really struggling financially, you're not likely to want to take on additional risk. So kind of an obvious point. And there's really significant variation in the quality metrics that are required across these different types of payment models. There's also, and this I think is really important, some real uncertainty, even within that group of clinical and health plan experts, to see whether the savings accrued associated with a value-based model actually accrue to patients. Right? So are those savings accruing to the institution, or are they going back in the form of lower premiums and lower healthcare costs? That is an unknown. And so I just want to call that out as very important. Future discussion, the group really recommended that this task force consider how to strengthen value-based payment models, especially through better collaboration and investment in primary care. So those are two themes that sort of emerge with those two topic areas. So we're going to have a chance to react to those two areas, and I want this group to raise some questions as to what you would want to talk about and see as potential discussion in May. They also shared a little bit of reactions to date on this group's work broadly. So they appreciated the group's focus on both near-term and practical changes with those longer-term transformational reform. They appreciated the focus on prior authorization as a significant pain point, but noted that this is a utilization management tool. So let's recognize it as that and ensure that there's sort of safeguards in place. It's not about removing prior authorization altogether, but what can we do to streamline that in a way that eliminates wasteful spending? Finally, the group also recommended considering the patient experience, and this has always come up with this group, that really we're talking here about deductibles, out-of-pocket payments. Let's continue to keep that orientation. The group also highlighted some of the things that this group has mentioned in the past, and so we wanted to just share it back with you. Price transparency, price variation, site of care differences. Those are all areas that that group also feels that there is some energy and opportunity for this group to continue pursuing research and policy development. They did call out pharmacy benefit managers, pharmacy-related costs as an area for potentially waiting to see what happens with PBM legislation, lawsuits, federal drug pricing changes because of so much sort of volatility or change in that marketplace. So I just wanted to name that for this group for question and discussion. And finally, they did, as this group has said as well, really or encourage a focus on the full system because all of these issues are going to be interrelated. We can't sort of only focus on the commercial market, for example, without considering implications across different markets. I will pause. That was a lot. I know you have it in your packets. What questions are coming up for you all, and also just help us think about when you come back together in May, what do you want to see come out of that discussion so that you all have some really meaningful sort of topic areas to weigh and potentially pursue? John, start us off. I hope so.
That every leg's on the stool. pay for it and how they pay for it, who uses the care and how they access it, who provides the care and how they, I think with the value-based care payments and the plan design stuff, it addresses those first two. I think as you think about Minnesotans accessing care, it's a variety of means. Commercial is employer or insurer, Medicare, federal government, and Medicaid state. I think as we get into May and beyond, thinking about some of their topics, we might want to focus on the state Medicaid plan where we can actually impact affordability for Minnesotans. I think the other two may be more challenging from design and affordability standpoint, but I just want to thank the committee for the work they did, and I think it's very well aligned with what we can do to help bring up some ideas to joy transform.
Thank you, John. Yeah, Matt.
Yeah, both of the care provider task forces meetings, and I was pleasantly surprised at the number of people who spoke. They use different terms, often very violent terms. And making a change here just pushes the balloon out somewhere else. And we try to do this and we try to do that. It just keeps being kind of a moving target. And then if we want to make significant change, or we want to really change affordability, at some point, we or the center need to be thinking about more significant changes of the system itself, and particularly around where how us incentives. And I would just say I was pleasantly surprised because these were payers and providers who are in the structured in the current system. Business models in the current system is not something I was expecting them to say.
And Justin.
These are just sort of what's sort of needed. And I will admit I haven't had a chance to watch those meetings and still need to. I think I'm just sort of curious. One on the value-based payments. This is maybe my own ignorance, but sort of how that differs from like the HMO model that we've had, and we now have I think since we last met, or maybe it was right before we last met, we now have a proposal from the governor, suggesting we shift away from that, and so we have recommendations, heavy on that same side, or we just kind of continuing down the path that we've been on, that hasn't seemed to result in affordability. I guess it's my personal sort of pushback on the idea that the utilization is sort of the key issue here. And then the other thing I would say on the PBM issues is I would just urge maybe a certain amount of urgency to those issues instead of a wait and see. Looking at a text because someone just sent me a note. We've had just in the last 12 months, we've had 10 pharmacies in Minnesota close. We've lost hundreds over the last couple of decades, and so I think that there's just a certain level of urgency to addressing that issue if we're going to protect healthcare access, particularly in rural communities. But everywhere in the state, pharmacies are feeling that pressure. So, thanks,
Justin. Thank you.
Thanks, Alex, and thanks to the committee for all the great work that they did. I feel sort of we're living in two worlds here around this table, and that is depending on the day and who's talking, we're either popping the balloon and blowing everything up, or we're participating and just poking at it, and it feels incongruous, those two. I don't have a clear idea. Today you said something, Alex, that maybe you've said every single time, but you talked about setting the course for the future, not about solving today's problems, but that this group is here to chart a course in perpetuity. And so I'm challenging myself because I'm a person who typically reacts to the current state of affairs. But I also see the value in perhaps the charter of this group really is to pop the balloon. And if so, then these topics that are on our paper today are not necessarily the things to start with. I'm thinking bigger and bolder things like healthcare as a utility, or only nonprofit healthcare in Minnesota as a model for the rest of the country. I know we were there once, and what would happen if we return to that, or no fee for service, period, end of story. So I know these are perhaps very far-fetched, but I think in order to blow up the system that we all say we think needs to happen, we have to be bolder in what we're aiming for. And then I also will say, because there's so many current issues like PBMs, which are undermining and unraveling so much of what we believe is good in Minnesota, perhaps we have two swim lanes, and one of them is let's take on something that is on fire, and also at the same time in parallel take on the big bang.
Thank you, Sheila. Julie, anything you wanted to add? Without a mic.
Have your advocacy for bringing back to the, considering something more timely. Sort of official policy did not come up at that discussion, probably because we also really appreciate you bringing kind of term issues as, so I think that is a challenge we need to face, right? It's sort of like the balance between sort of the up until now have called like the tactical changes versus the fundamental changes. And I'm curious, Sheila, if you thinking about if we were only going to go, those are really big picture things, and I think you're right, they require coming at things from a different direction. My question to you, I think, might at this point sort of the issues that we have out on the table today sort of come our discussions of that group. And I think we need to charge ourselves also with thinking about that longer term fundamental change looks like. I don't think they're mutually exclusive.
Yeah, Marie.
Yeah, I mean, obviously, I agree with that. I think we would probably be well served. I mean, you can see the building blocks, and of course, we have to start with some things, right? I get that. We better start nibbling away at it somewhere, or we will just feel like we have to boil the ocean. But if we're not doing that in service of kind of a big, bold vision, I mean, you could take some of these regulatory pieces and say, we are going to look at those in service of, or the marketplace structure, the influence of private equity and all those things in service of a radically more transparent and differently regulated system. And that then we have a vision for where we're going with the pieces that we have to get started with. That would help. That would help me. And then I'm also reminding myself of our true north of the number of Minnesotans foregoing care due to cost. By the way, asterisk, we can't forget that some Minnesotans will begin to forego care due to access to a pharmacy, a rural hospital, a large urban safety net system going out of business. I mean, those things all are huge also. But if we're going to try to limit our focus mostly to cost, I still don't know, like, okay, so we come up with a different system of prior authorization because it's so irritating to all of us. But we still say we want to steer patients to high value care. So are we just going to come up with a different steerage mechanism that's not called prior authorization? I mean, certainly we can come up with something less irritating and more effective than prior authorization, but to what end? You know, does that, how many more Minnesotans will not forego care because of
Mhm.
that? So,
Mhm.
I mean, I think it's not, the tactics are hard enough in and of themselves, but I think they need to be in service of a bigger vision that I think we have or can begin to have.
Yeah, John.
Items that they identified as cost issues that we've identified as well, that regardless of the long-term strategy, the prior auth was one, credentialing was another, or maybe there's a role that we could play with recommendations that will eliminate some of the redundancies and inefficiencies in the system, that regardless of where we're going, we could probably help the system.
Mhm. Mhm. Thank you.
Just in, a question is, how is this group, there are lots of people talking about prior authorization. And some of the other really valuable items on the list, John, you're right, this is an amazing list of potential cost savings opportunities, but how is what we're doing, who we are around this table and what we're doing different than everybody else already working on prior auth? As an example, I think that's, kind of at the core for me is what is our value add here. I love talking and learning from all of you, but I don't think that's the point. So just keeping in mind that we're not the only ones talking about prior auth.
Thank you, Sheila. And it's not the only sort of point of coordination, but I didn't want to miss an opportunity to just remind this group that we are convening a virtual meeting in May 20th, that you are not required to join, but that we will share out the inputs from. That is with consumer advocates. We'll have an announcement at the end of today's meeting, but just wanted to put a plug in for it. And we'll be sending out some more information via kind of GovD, a newsletter. But that is one of the purposes of that discussion, is to hear about what are others working on. Can we talk about aligning and figuring out what is this group's unique position to offer a space for bringing the evidence to light, taking a really focused look at what is driving healthcare spending, and taking a focused look at what the options would be for Minnesota. Yeah. Yeah.
That bigger.
Universal. Mhm.
So I think all of when sort of like question and attrition that large.
Mhm. Yeah, yeah, and getting some prioritization information from this group today, I think could also help inform how to sequence the results from those studies for this group to react to. Do you want to add, Stefan?
Benefits are no question. So as far as affordability, Joe is concerned, change, different your top for incentives. Administrative expense study that aims to estimate across the system. To provide also process Joel's. That study kind of was around the edges. Thing. The idea, structure of the model. Is a better. So. That is when they come. Trade-offs of quality. Same, so changes driven by a set of particular people spending should.
And just so you know, I'd like to regulate more than just the payer side of things. So I have something bigger and broader in mind. So.
Follow-up question. You said June for the administrative cost one. Can you remind us when the single payer is supposed to be up?
It's due earlier this year. They were joke. First of all, we say these days, summer. Which part of summer?
Thanks. And just, can we just
Summer 2028.
put time on our agenda whenever they reach out to hear from the people? Next question.
Thank you. Mhm.
Just real quick, sort of building off that exact point, I just wonder if there's a, obviously it's, the policy landscape's always shifting and it's impossible to kind of get a point in time, shared understanding, but particularly as the legislative session wraps up and we do move into summer, I'm just wondering if it makes sense to take some time at some point. Maybe it's that first study when it comes out in June, to not only sort of talk about that study, but maybe just also kind of talk about like the landscape, what happened in the legislative session, what legislators are talking about, because I think that can also maybe help with. I've been thinking about Sheila's point that what's our unique value add. There's, some of the recommendations here today, I really love, but are also things that maybe have a little bit of momentum in the legislature and not necessarily where we have the biggest bang in for the buck and weighing in. So just something to further derail the discussion away from the payer provider task force, but something else to consider around that sort of shared understanding of the discussions at the Capitol.
Thank you for this input. And what I'm hearing is lesson orientation to like, yes, let's talk about these two particular topic areas. And it's like a bit of a zooming out to ask, can we talk about a vision? Can we talk about our unique value add? Yes, these are maybe two topic areas that the Provider Payer Advisory Task Force is going to help us lay the groundwork for. But is there something maybe a one step before that we could spend a little bit of time on and making some recommendations and setting, charting that course. So we will do some thinking about how to use that time in May so that you're really able to get into that. Since, we want to use your time wisely. We're a little ahead of schedule, which is just fine. Go ahead, Marie.
Yeah, well, I mean, Stefan, can you give us a high, medium, low in the administrative cost report? Like, again, if I'm thinking about how many Minnesotans are foregoing care due to cost, and let's say we got everything on this list down to like all the administrative stuff cut in half. I mean, healthcare is not going to administer itself, even though we wish it would. What are we talking? Like what percentage ballpark? I mean, because then we save that and then some stuff keeps growing anyway. Like what's this gonna get for us is it gonna get us 100 Minnesotans not foregoing care, 10,000 Minnesotans not foregoing care? Like, what percentage of the whole thing can we possibly save here? Yeah, I know,
response.
of course.
And we're not ready with. I think, um, as with a lot of things, these are policy choices.
Mhm.
If you are, as a community, just that you're willing to choice, there will be more, some choice. Be greater administrative savings. There are trade-offs between ensuring that there's no waste and ensuring that we have understanding of the quality of care. There is a single payer system. There will be administrative functions that remain, like Medicare dollars. That we have to demonstrate that we are Medicaid, and we have to demonstrate that even if we have a person that is willing to contemplate Minnesota, well, we need to think about how to ensure that people who are eligible receive the Medicaid payment are supposed to get in a budget neutral kind of setting. So the how much administrative spending came depends on how you want to design the system to balance those trade-offs. I think the other point worth remembering is when you reduce administrative burden, you don't, even if you don't change reimbursement, that's effectively an increase in reimbursement. So in prior authorization, every day is 20 to 30 side. If that is reduced by some extent, that's revenue that can retain. That's what we wish to activity. So, short answer is it depends on the making the changes and what extent necessary to get transparency in the system. Quality, text processing, all of those things. Yeah, that was a really satisfying.
Mhm. Accurate, but unsatisfying, yeah. So thanks.
And-
I know. I mean, but it is in service of like prioritizing where are we going to
Yep.
spend our time?
Mhm.
You know, if we're going to get rid of prior authorization, I mean, I'm picking on that because it's easy to pick on, you know, and still have some other mechanism to direct patients to high value care. Well, you know, we just swapped out something for something. Maybe it's a better, less annoying something, but is it going to save us money?
Yeah.
To some extent, it reminds me of what Jared Eagling always uses. So it's really easy to talk about efficiency.
Mhm.
But it's really hard to make cuts, changes, because somebody's experience is poor rather than it's going to change.
Or what Uwe Reinhardt said about, you know, United States being the only country that spends $100 tracking down one in Medicare. Yay, us. So
I appreciate your points, Marie, because I think what you're getting at is how are we going to do this prioritization exercise, even if we don't know if the juice is worth the squeeze? And that is why we wanted to start talking today about factors for consideration. What we are calling factors for consideration. We are taking new naming conventions. We don't need to call them factors for consideration. There may be better ways of talking about this. But basically what Maria is getting at is like, how can we score or rank or think about these different directions, they're not even policy recommendations at this phase, in a way that is rigorous and based in the priorities that this group has laid out. And so we started doing that to try to offer something on your behalf, to try to like reflect back what you all offered us in those 60 sticky notes. And this is sort of our process for doing that. And the intent here, the reason we're doing this is not sort of to explain our methods necessarily of like why are certain things on the list, but rather to say what is going to be helpful for you all to do this exercise going even into next year, let's say. And like what would you guide the center to use in terms of factors for considering potential direction? Is it questions about numbers of people that would likely not forego care due to cost, right? Like that probably is something that we would want to better understand the impacts of. So that's why we're doing this now. So these were the original selection criteria this group talked about back in October of last year. And you talked about kind of binary concept, which was very appropriate at the time to just think about, are we going to pursue potential topic areas that have an impact, that have a significant impact on healthcare spending, totals? Is it going to be system-wide or more relevant to particular markets or payers or service types? Is it ongoing, going to reveal one-time or ongoing savings? Like I'm just kind of naming a couple of things I'm seeing here that are still, I think, very relevant to this discussion. What we have done is taken this and just provided to you a new sort of reorientation to these selection criteria to be a bit more qualitative, so that you all can think about using a framework, these types of directions, and even as they get more specific and become actual policy recommendation options, you can think about the different merits of these different directions. And so you'll see a lot of repeats from like these kinds of questions and categories to the selection criteria you offered in the beginning. Things like, to what extent is this intervention going to reduce healthcare spending growth? Is it going to reduce foregone care due to cost? To what extent can we attribute that action to the impact? And to what extent do we care? Like, there's going to be lots of different changes in the marketplace. I won't go through and read all of these, but I'm just naming that these are these different categories that we have tried to take those selection criteria and place them into a broader framework for you all to then take forward in your thinking, knowing that we can't really rigorously yet apply these because we don't know yet the answers to these questions, because we're still at such a high level. What you see on your sheet there's two tables. I just want to orient you to like what this is so that we can start thinking about these factors both for today, but also even going forward. Table 1 is a list of synthesized recommendation areas, topic areas for potential future research and policy development, synthesized from your input to date and from the provider and payer advisory task force's input to date. You'll also see on table 2 a list of that same sort of set of topics, research areas that we might consider as continued areas for attention and consideration, but they may not be rising to the top with respect to like, these are going to be the things that you want to start with. And that might be for a variety of reasons, whether it's because it's maybe not this group's sort of unique position to be able to help and weigh in on it, or maybe it's, there's just no other states trying anything in this area, or maybe there's just very little data to show that a particular one of those things on the second table are going to actually improve affordability for consumers, but they're still worth sort of keeping on the list and considering. And so we wanted to reflect back to you the full sort of universe of what we heard, and also offer you a little bit of thinking as to our initial take using a framework like this, using sort of what we know about this, the landscape, to just help you all make some, have some discussion. I want to be very clear, this is not a reflection of like, you need to take this and just check it off, right? This is intended to be, here's a first step, a first pass as to where we think that there's worthiness for future research and and analysis and policy development. On table 1, some of those recommendation areas are in blue. We will go through, that's what we're going to spend the rest of basically our time together today, looking at table 1 recommendations. In other words, the recommendations that sort of emerged for us, at least on a first pass, as being the most worthy, having the most potential for future research. You could imagine if this group says, we'd really like to start with, I'm going to just pick on 1, 2, and 3. I don't even know what is on the list. The sequence, the numbering does not illustrate priority. The sequencing is just for your discussion. So you can quickly refer to 1 or, number 7 or whatever. If this group were to say, we would like to start with 1, 2, and 3, or whatever number, you might imagine our agenda in August, September, October would really form around those recommendations. And that's really what we're looking for your input on. I also want to say that this is not the last time that you'll get to see this and that you'll get to edit them and move them around and reflect on whether they merit, further attention. So that is what's on this list, and that's how they're related to this initial set of factors for consideration. What I would like to do is just have a discussion about whether this approach is reflective of how you might imagine wanting to look at this list, as well as even in the future, how you'd want to continue to look at potential policy recommendations. And so I recognize that we can't, to Marie's question, really answer all of these questions yet because the topic areas are quite general. But we need to get to a place where we can start to answer them. And that's what we need your help to say. Let's start with these 3 so that we can start to answer some of these questions. I want to see if Matt wanted to add anything more to that, because I know it's a bit, wanted to offer you to offer.
This list is a static list. From the task force. Something else on the list that we put up.
Mm-hmm. So who has my first reaction to, is this making sense? Is this lining up with how you would like to be thinking about these topic areas and future recommendations?
And clearly this, I don't know how long we're all going to live, but this could take us a long, long time to get through this great list. Just today's conversation, what Stefan shared about this administrative cost report makes me wonder, is there a column to add on here about current status of understanding or research or investigation so that we know these are not all equal in terms of their formation and in our understanding, or MDH's understanding for sure. So, you pick administrative waste, even though it's not in blue, there's something big about to come out that there's nothing for us to really talk about yet there until we see that report. And then I would jump to one that I feel really passionate about, and that's number 12. There is a very large system in Minnesota that's about to be acquired, and there's probably a ton of activity going on in that regard. And so we need to be privy to it. We need to just decide this isn't our space to be, our sandbox to be playing in, but this one is a really hot topic. And I think it would help us to understand who else is working on it, what are they talking about, and what perspective are we supposed to bring? I have a lot of opinions, but I don't know what our charge is when we're looking at something like that.
The other thing I would add, it just,
Thank you,
it
Matt.
sounds so booming. Thank you to the folks online for putting up with this. I think part of what's underlying this, or at least the way that I think of underlying this exercise of trying to create priorities, is the recognition that we have sort of limited capacity among the center and the Department of Health and our partners. We can't do everything at once. We can't. So I think it's incumbent upon us to provide, if we can, provide guidance. These are the first areas, or these are the highest priorities, or these are the low hanging fruit. I don't care what euphemism or cliche you want to use, but trying to say this is where we have our greatest bit of interest. And so investing time and resources here seems to make sense to us, recognizing that means those time and resources aren't being spent, or at least not as intensely in other areas.
Yep. Yeah, Stefan. Maybe when we get to the high and variable prices and have a moment to start to discuss the rankings, because yes, this is an area that I know a lot of people are interested in. The Attorney General is starting to publish some things about it. So yeah. Yeah, Marie.
So again, all the lists that you have provided and the way you have framed the factors for consideration are great. That's a great list, very helpful list. But, and I'm struggling with something here, but I think it, though, supposes that all of the things from which we are considering are all in service of our vision. So like everything here would serve our vision, and that's how we could sift through them to pick among them, because we do have to prioritize. Except I don't know that we are in service of that. I don't know that we have that larger goal, that larger vision kind of spelled out, like where we're, like, if all of these things worked together, the impact, this is, because we're heading toward this big audacious thing out there, and these things would all support it. And then this would be the list, how we would pick among those things. But I don't know that we have everything in service of a vision yet. So, I mean, and that kind of goes back to a little bit about, I think what Matt and Sheila have talked about in terms of like, how does this all fit together with what's going on? And again, we find ourselves in this very awkward time right now in between administrations and legislatures. So it's a weird time. There's a lot going on, but then again, there's some big gaps of what's going on. So where do we fit? What's our vision? How does it fit into what everything else is going on? And then these would be the factors to definitely, we have to prioritize among the things we're doing, because we'll never, Sheila's going to live a very long time, but I have less policy life left in me. I can just tell.
I think if I can, I think, at least the way that I understand it, I think that when we think about the impact, I think reducing healthcare spending growth and reducing foregone care due to costs are the sort of North Star, dual North Star. I don't know if that's not in our galaxy, but somewhere there's a dual North Star. And so but we don't know necessarily which among these are going to move us toward that North Star. And that's part of but we won't know until we dig in and we do more analysis, but we have to pick, where do we want to start? Second is, we are in a dynamic political, economic, healthcare, we always will be. And so we need to be thoughtful. We need to have a process and discussion, but we're never going to be in a situation where we say, okay, now the time is right. It's always the right time and it's always the wrong time. Because it's going to keep changing.
Yeah, I mean, I totally agree. I totally agree. It's just that we have to keep in mind, what is that environment that we're in? Maybe another way to think about maybe a different factor of success is what's our chance of success? Or even for consideration of our, like in our role, whatever it is in the environment, what is the chance that we will even get this idea out into the atmosphere to have it considered? That's a thing that's not right there. And so maybe there's an not North Star, but maybe there's a lower planet or something we're aiming for. That's like, this is the idea. If all these things came together, look what we'd be able to do with the system in Minnesota in a different way than it is now. Maybe.
Yeah, Stefan. I mean, wait, actually, can we go to Andrew? And then, because just students, you hadn't had a chance to speak up.
I guess I just have a quick question. Are we blowing up the system or are we living within the confines of what we can do now? It seems to be conflicting, like.
We have a system, I mean, it's not a good system, some concerns about the system, but I think you can say, this is what exists. Can we reduce costs however that exists? Are there ways that we can identify things that we're spending money on that we shouldn't be, or that we can spend less on, or whatever? And at the same time, or in parallel, I think getting to a little bit more of what's been discussed today of what kind of system do we want? So that we don't have to be constrained by only working within the system that we have. And I think that those two exercises are both valuable. I think they do go to Marie's last point. What is more likely to get traction and to get attention? I think we've seen throughout the years that one set of recommendations are more likely to be picked up and move, and the other set of recommendations are more likely to be talked about and much tougher to get action. Does that make sense?
Stefan, sorry.
I have a question. When you were starting to talk about it, and I appreciated that you sort of said, well, we're always going to be in touch with you always experience political change. One of the items that I am struggling with right now is that you are having at this table a discussion about affordability. Legislature right now is having a discussion about hospital bailout, putting more money into the system. And I wonder how you are thinking, or what help you need from us, Alex, how you want to guide the conversation to absorb some of that contradiction. Yes, HR 1 will change things down the road, but we are having multiple hospital systems talking about the fear of closures, precision of services, etc. And that is before the reality is hit yet.
Mhm.
How do you think, how do we all think that it interacts with our concept of affordability, which is not about putting more money into the system, because there's plenty in it. If we can't afford the care and making changes and preserving access.
Mhm.
I didn't mean to make it more difficult, but that was the contradiction I thought you both were going to focus.
Well,
Yeah,
we don't
right.
have to have this whole, I see a way that there's not a contradiction. I mean, I see elements of a path forward. I mean, I think what the hospitals are suffering from right now, and what a lot of healthcare providers are, is this immense cost shifting that's going on. Things they used to be able to shift around inside the system have gotten siphoned off through these business practices, some of them private equity, some consolidation, some other things. And so those are the profitable parts going away, which we don't have a line of sight into because we don't regulate healthcare in that way. We don't have transparency into the way those financial structures are going. So now what we see is what's left over is the safety net hospitals, hospital services that are less profitable in areas that are less profitable. And so basically there's a big cost shift that's going out there behind in a black box. So I see the elements of saying, no, let's get eyes on that here in Minnesota. And then maybe we can understand if there is a need for state infusion. It's a lot harder to do, and it's a lot, the timeline is out there a lot farther than what the hospitals need right today before they go out of business. But I don't see it as a contradiction. I see that there's elements that we could get, that it all makes sense to me. So we can have this offline if you prefer, but I think there's a way to make sense of it, but it requires us then to have that vision and an understanding of where we fit in the environment of the other things going on. And I totally agree. There's always going to be legislative policy gnarliness. For our particular purposes, working with a state agency, it is a weird time for a state agency to be going like, here's our bosses this year, and we're going to have different bosses next year. So I don't know what their priorities are going to be. So it is just a particularly, all the weird times that we find ourselves, this one's particularly weird.
Good, John.
This conversation makes me ask the question of who's watching where the puck is going, since we're the state of hockey. Medicaid changes are coming, and they are going to be catastrophic for rural hospitals. Right now, you can look at different studies, but for every dollar of revenue they get for a commercial member, Medicare is 60, Medicaid is 40, and their costs are somewhere in 70. They're already losing money for Medicaid, and it's going to get worse with the changes that are proposed that you alluded to. So that's why I think the state Medicaid program might be something that we need to pay attention to as we think about design, funding, and so forth. So who's doing that? Can we help influence that? Back, Marie, to your point, what's the bigger vision and strategy, and where can we make sure Minnesotans have access to healthcare, and we have hospitals that are open, pharmacies not closing, maternity wards not being shut down, and especially in rural America. And some of the, Hennepin Health is a great example of the mix issue you talked about, Marie, and it's going to get worse. And how can we help it?
I want to shift us to start looking at some of these tactics, recognizing what I'm hearing in this conversation is a desire to step a little bit backwards, take a broader look at, and maybe it's at the end of the session, there's sort of a little bit of a pause where we can look ahead to a new administration and just revisit that vision and unique positioning of this group. I appreciate, Matt, you reminding us that maybe we do want to have a little bit more time really talking through this about what this means, but I do hear this group really orienting to those dual North Stars, or however we want to call them, of we want to see total healthcare spending growth slow so that we can afford the system of the future. Right now, it is growing at a pace that is faster than most other economic trends. It's growing faster than inflation and cost of food and education, things like that. And so what could we do to bring that growth into control? And the other thing is the factor that Marie raised, which is, can we see fewer Minnesotans foregoing care due to cost? And of course, there's lots of reasons that will increase because of HR1 implementation, for example, and that's not going to be sort of this group to solve that whole problem. But I name those two factors, that sort of system level and individual level, as like the longer term goal. Are there interim goals that this group wants to name? That's maybe a question that is worth kind of rehashing and kind of coming back to, so that even as these sustainability issues continue to come up, and they will, hospital sustainability, rural sustainability, we can continue to sort of set our sights, or this group can continue to set your sights on a longer term vision. So with that, I do want to start to get a little more into the weeds, recognizing, this is the way we're going to facilitate this discussion today is really about going through these recommendations. I want to note, these are all reflections of what you all have told us, but nothing is set in stone. And so we would urge this group both to be thinking about and making recommendations on where you might prioritize these concepts, as well as how you would word them and what is missing, right? So I recognize by saying what is missing, it's kind of like opening up this huge can of worms. I think it's okay for us to say, there is a broader universe here, and that's okay. We can continue to, hear that input. Today's topic areas that you'll see on the left-hand side are all really related to high and variable pricing and non-value added spending. And that's just because those are the areas this group has worked on. But again, this isn't going to be a one and done. Hopefully we'll live forever and we can just continue working on it. But the list is long. It will get longer. And we urge you to just help refine it. That's one goal that I have for today. Julie, do you want to jump up here then? Okay.
It seems like the mics along the back of the room, those are working well. Over there, you guys need the lavalier mic. The one that is in front of Stefan right now is not great. I know there was another lapel mic that we could have had. I don't know if we can maybe sort of get that, but I want to make sure that the folks that we have online can hear us well. Excuse me. So Alex already gave us a little bit of an introduction to kind of how we're going to do this, but I am just gonna like sort of set the stage and sort of tell you what our plan is for how we're going to sort of accomplish this prioritization. So Alex described the tracker that you have, and our plan is to do this separately for the the ideas that are in the non-value added spending bucket, and then repeat the exercise for the high and variable prices bucket. So that's one thing to know. She already alerted you to the fact that the rows that are in blue are things that sort of MDH has kind of put on its list as potentially higher priority things that could happen in the nearer term. But as we go through it, I'll tell you, we'll talk a little bit about the ideas, clarify if anything's not clear, ask MDH to give their perspective, ask Matt as the co-chair to sort of weigh in, and then we'll open up the discussion to the broader group. And at the end of that, our plan is to sort of do this exercise where we sort of have the instant polling to kind of help us get a sense of which ideas have momentum for the group, and that will help us figure out where do we want to dive more deeply in May. We will also want to know from you, what else do you need to know at our next meeting in order to be able to continue making progress on prioritizing this list. So, it is not the only list of things we will ever talk about. Yes, we're still going to sort of talk about that. We're going to zoom out at some point and talk about like what is that broader vision, but I think it is consistent with the conversations that this group has had about like, we need to be tactical and we need to be visionary. So today we're being a little bit more tactical than visionary, and I hope that's okay. So just as background, especially for the folks who didn't have the opportunity to see the whole list ahead of time, there are 6 items on the table 1, which I guess is the potential recommendations list that are in the category of non-value added spending. And you will probably recall that we've actually talked about 2 sub buckets of non-value added spending. So one of those is administrative complexity, and the other one is kind of this institutional and investor related spending, things that kind of just extract profits from the system. The 6 items on the list include things in both of those sub buckets. So the first one is to develop and evaluate options for prior authorization reforms. And there's a lot of, there's a few things that are given in, I'm not going to read these bullet points to you, but there's a lot of things that could mean. And one of the things that we would likely do if this idea rises to the top today would be, okay, let's start looking at like the various components of this bullet point and think about which of the things within that idea are the most meaningful to drive forward. So what we're looking for is direction from you all today. The second item on the list is developing options to improve state visibility into ownership of healthcare entities. So this gets at the private equity, other types of ownership structures, and safeguards to prevent things that increase spending without producing consumer benefit.
The other items on the list are estimating spending on administrative waste. We talked a little bit already today about the study that MDH has coming out about administrative spending generally. So we are not looking to answer the question today about like how much money will we save, but we need to know how important is it to this group as a priority for how we should be spending our times. We've also talked already today about some of the ideas around provider credentialing as a way of reducing administrative complexity and administrative cost. The PBM issue has already come up today. So analyzing the PBM financial practices, including rebates, spread pricing, all of the many complexities of how we pay for prescription drugs. And then the final item on the list of 6 that we have right now is estimating the prevalence and costs of low value care and identifying opportunities to reduce it. That again is a topic that MDH has a study in progress on. I will point you to in the handout, not the slides. There's a few items on the in the non-value added spending bucket that are things that when MDH was sort of just cataloging all of these things, thinking potentially are things that are not things this group would want to do in the consider for recommendations in June, but want to keep on a list for future consideration. I want to be clear that like we're looking to you today to tell us, do we have this right? Are there things from page 2 that should be brought forward to page 1? And we have the flexibility in sort of the discussion and the sort of the polling options that we do to kind of change those a little bit on the fly. And I'll look to my Mathematica colleague, Henry, who's online to correct me if I'm wrong about that. He's kind of like he's in charge of the polling, but my understanding is we can adjust it if we decide we would like to modify one of the items on the list. So kind of here's what we're hoping will happen next. So MDH will give us their perspective on sort of how it is that certain things landed on list 1 versus list 2, kind of what that looks like. I'll give Matt a chance to weigh in. We'll open up the discussion to the broader group. So you can argue to put something from list 2 onto list 1. You could try to persuade your fellow task members to, when it comes time to like do the ranking, why a particular idea is like, a burning issue for you and why they should, rank it highly as well. All of those types of things you can propose modifications to the way that we've worded it. So all of those things are fair game and on the table. So any questions about the process?
This isn't exactly process, but just more definition to make sure everybody has the same understanding, including myself. The word value has been used 3 different ways. So we have non-value added. I'll say what I think it is, and then you correct me. Non-value added, it is administrative. It's waste. It's administrative waste. It's extra paperwork. It's tasks that don't add value to anybody's job or to patient care. We have low value, which I think is equated with overuse or care that is not going to help somebody get healthier or achieve better levels of well-being. And then we have value-based, which is paying for something that is a combination of high quality, safe, and lower cost. Is that the right way to describe it?
Yes. So I think you're correct to point out that like those, right? So that is the way that these terms are broadly used. There's a little bit of, I would say, ambiguity. So are you thinking about, are you pointing out the sort of the issues with the terms, or are you asking for us to clarify?
I may be the only one who needs clarification, but I'm imagining that other people who are new to this business and listening in might not understand. Right here on this one slide, the word value shows up as non-value added and low value care. And I just thought it would be worth making sure we all share the same definition, at least in this room.
Yes, so that's fair. On the non-value added side, and that you're right, that is sort of like the so it's the administration and the profits. It's stuff that is not delivering care to people. And they both contribute to costs that are higher than they need to be. So I think that's how I personally would describe that term. we have struggled so much with what to call this bucket. Non-value added doesn't feel like the perfect label to me, but I have not yet come up with a better one. So if we can come up with a better one, I think that would be just fine with me. And then on the we could. It's hard to come up. It is hard to come up with a term that is, yes, that doesn't sound judgmental. And on the low value care side, so your description of it as like things that are not improving patient outcomes, I think is accurate. I think it is also, many people would also say, is sometimes harmful. It contributes to spending. So like for those in the room that don't spend all your days thinking about, what low value care is, like examples that people often give are things like a colonoscopy for somebody who's over age 85 because they are likely going to die of something else before a colon cancer or whatever kill them. Not always true in every case, but that is one of the common examples. So it's one of the things, but there are instances when that can cause complications that make the person worse off. Or testing for certain kinds of conditions that can lead to like all kinds of cascades of unnecessary care for incidental findings. So that is what is commonly meant by low value care. I don't know that we can entirely solve the problem of confusing labeling because these are, right, it's just the lingo, but appreciate that you pointed out sort of the different ways that we're using the same word. Justin.
To me, there's a couple of these items on table 2, at least at quick glance, seem to have a lot of like overlap with other items on table 1. And so we don't need to, my goal isn't to like get into each of those right now, but I guess, is it part of our sort of like, as we go through this process today of, trying to convince our fellow task force members to bring things to page 1, is that a fair part of the like convincing? Is maybe not so much, hey, I think this is a great idea. It's, I think this on table 1's a great idea, and it's kind of being repeated here in table 2.
Yep. It could be like a friendly amendment. I think we should incorporate more of the ideas but also to clarify for right now, sort of like what's fair game to bring into the discussion from table 2 is items 15 through 18, because those are in the bucket of non-value added spending. Marie, go ahead.
Well, no, I also have a process question about if we see what are we supposed to do if we see something on table 2 that we'd like to?
So when we get to the sort of like the open discussion, you have the opportunity to say, there's something on table 2 that I think really needs to be its own, moved to table 1 or incorporated into something else that's in table 1. Or, I think this is unimportant and, it should stay where it is. So with that, let me turn to Alex to give the perspective from MDH on the current list.
How about this one? Maybe. Okay. This is a prioritization exercise. It's not a voting exercise. I just want to be clear that we will continue to come back to this list. So today's, we're kind of being a little glib and saying like, convince each other to put things on. The idea is you could slice and dice this list in lots of different ways. And it's also not mutually exclusive and comprehensive, right? It's not like every possible thing. And so this group really should be thinking about this as an exercise, and we should be continuing to refine them as we go. So that's one thought. In terms of just reflecting a little bit about like why things are on which list and why some things are blue. we did take some initial cut at like, to what extent might we see some potential impact on consumer spending, on consumer affordability, on total healthcare spending? To what, so some of those factors for consideration, right? To what extent are other states even taking some action in these areas? To what extent are there studies that are coming out from MDH that are like ripe for investigation and further study? And so that's some of the thinking that informed this. And so, for example, if we look at the two that are highlighted in blue that are on the non-value added spending bucket, number 1 and number 4, so that's the prior authorization reform potential direction, which would incorporate not necessarily getting rid of prior authorization, but it's a further discussion of what are the opportunities to make this spending less wasteful? Like, can we make it better? That is something that has been discussed, not just in this legislative session, it has come up a number of times, but also in past legislative sessions. And we are seeing our health economics program team conduct that administrative study with a particular focus on administrative functions, including prior authorization, and they will come out with some recommendations that this group can react to. So in other words, this is sort of a place that we feel that there is momentum. There are other states taking action. There are, recent studies that are going to come out that this group could react to. That's one example of like why that one comes to the top in terms of being sort of highlighted in blue. Number 4, same thing, ownership of healthcare entities. This is something that has come up a number of times, not just in this legislative session, but in past ones. And to Marie's point as to like some of the changes that we're seeing in hospital sustainability and of hospitals' ability to like pay its costs, this issue of ownership and not having insight into who owns different healthcare entities and different parts of healthcare entities may be bad for consumers. And so that is a place that that's why we see that continue to come up in legislative discussions. And there may be sort of unique opportunity for this group to sort of shed some light on what other states are trying and whether there's action that Minnesota might consider taking, as opposed to there's a number of other, perfectly viable and worthy discussions on administrative waste, credentialing, as well as like interoperability, right? Like there's some really important issues that are listed through here that we can certainly talk through, but that didn't to us kind of come out as like this group can uniquely weigh in on some of these issues, or there's like a moment for these topics for, immediate action in, let's say, August, September, October of this year. Questions?
So I'm a little confused. You said on the other page, 15 through 18, why wouldn't we talk about 19, which analyzing the main drivers of commercial price?
We will when we get to the second. So like we're trying to do things in sort of we're going to do this exercise twice. We're going to do it once for the non-value added spending bucket and again for the high end variable prices bucket. So we will get to that one today for sure.
Matt, do you want to say anything more about just what you're seeing on this list or how you want this group to be thinking about the non-value added spending bucket?
In the interest of time, I'm a little reluctant to add in. I think we should try to get the conversation going and have Marie do her modern interpretive dance to argue in favor of moving something from page 2 to page 1 or whatever else we're going to make her do to earn our trust in that. So I think I'm more interested in getting task force members' input than.
Sounds good.
Yeah, that sounds good. And sort of, just to kind of make sure that we're all sort of like where we are. So we have the poll that we'll do right at the end of this, close to the end of this discussion, because I think we also want to make sure once we have sort of done that to sort of just kind of see which things have momentum from the perspective of the task force as a whole. We also want to understand from you, okay, like what else do you need to know in order for us to be able to bring more information to you to kind of weigh in terms of thinking about potential recommendations. So I think we have about, let's spend about the next 15 minutes sort of on the open discussion about like how you feel about the ideas that are here. Hopefully you see the discussions that we've had to date reflected in these ideas, because I think every single thing on here has been a point of discussion in prior meetings. Many of them are things that were on the sticky notes from the brainstorming sessions at the last meeting. But, what are your sort of thoughts and reactions to what's currently on the list, I guess? If you want to just reflect on what you think are the sort of the highest priorities from the list, just to sort of inform the discussion and thinking of among the task force as a whole. So who would like to start? And I know Jamie is online. I want to invite you to jump in whenever you see fit. Trying to keep an eye on if you have your hand raised, but also feel free to just jump in if we're not noticing you. Philip.
The list looks good and makes sense to me, seems reflective of the discussions. Number 4, which is one of the 2 highlighted in blue, is the one that kind of jumps out to me as the highest priority among these in terms of, there's so many factors and criteria to weigh, but in terms of the ability for this group to kind of bring sufficient attention to something that's kind of a big newer changing piece of the system, and see if we can get to some recommendations. So I think that's my input. The question I have is on number 2, with the reminder from Stefan earlier about the study that's coming out. It seems like this is maybe, tell me if I'm wrong, but this is maybe not stated in the correct way to be considered here, because I think the estimation of the total spending is happening. We don't have to do that. And then my question is, will that report have policy recommendations? And if so, then the whole thing is sort of, it's important, but it's already happening, so we don't need to do it.
Philip, thank you for pointing that out. Yes, the report will include policy recommendations. And again, this list is totally not mutually exclusive and comprehensive. And so you're pointing out, for example, that some of those recommendations will relate to prior authorization, right? So that's kind of related to number 1. So appreciate you calling it out. And because it was such a big theme, like all of the different administrative functions named, as I'm thinking about the sticky notes on the wall, it felt like we need to reflect that back. So my question to this group is there a better way to reflect all of those different elements that this group has talked about around wasteful spending that is not necessarily a prior authorization specific issue? And if there's something that's missing, like, let's add it.
Hey, can I also ask a clarifying question? And I don't know if you know the answer about the administrative cost study. So I think I recall that the charge was administrative cost. Like, will the study actually identify like what's wasteful among that? I'm just thinking about like different levels of granularity. So like maybe we'll know how much money is spent on marketing, but it's not like you want $0 spent on marketing, or those sorts or credentialing is another good example about like what are the opportunities to streamline. And I just don't know how much information is really available to kind of get that deep.
Yeah.
Mention the credentialing one, because that's one that I keep hearing, but I have no idea if it's this big or this big. So I guess I'd ask that with MDH, you got this other committee of experts on the payer and provider side. What's the research on what is credentialing really costing us? And if we did do a state credentialing hub, what would that look like, and how much is that really going to save us? Is that juice worth the squeeze on that one? I don't know. A couple other things, the PBM side, you've added 2 more potential ones on the back, and they are all different twists on the same theme. But the comment of pharmacies closing, I find intriguing. And what's the impact on consumers? How relevant is that? It'd be great to see some data on Minnesota on how many pharmacies have closed and where. Is it a rural issue? Is it a metro issue? And why? Was there something we could have done to have kept them in business or avoid the next one from closing? So it's kind of alluded to a little bit in some of the vertical policies or processes. So I'd like to learn more about why are pharmacies closing and how big of an issue that is, and how can we address that in this PBM topic.
Are there ways that we can like rephrase or combine those ideas? I don't know that pharmacies closing is really reflected in the words on the page right now. And I don't mean to put you on the spot, Justin, but is there a better, are we asking the right questions
There's the
there?
vertically integrated pharmacy requirements on 17, which I think it's some of the reasons maybe they're closing and the way they're treated financially. I don't know the issue that well, so.
I do think, yeah, I think sort of like pulling these three together into one might make sense, because I think there's overlap there. Um, and I think that one of in terms of pharmacies closing, and maybe what makes this sort of a, kind of an interesting issue, going back to like, sort of that grounding and like affordability, right? Is the, pharmacies are closing mostly because they're losing money on the prescriptions that they're filling because of the PBM reimbursement policies. The thing is that while they're losing money, it's not like any of us are saving money. And I think that gets lost sometimes in like the discussion of how we deal with this. Is, there needs to be more money flowing to pharmacies. It's just not necessarily that has to, like, ideally that's not just like layered on top of the overall pie of money we're spending on prescription drugs. It's that there's PBM sitting there in the middle, kind of taking all the money, from my perspective at least. So I do think the closure issue creates an access issue, which in my mind at least does kind of like, is an affordability issue, although again, like it's harder to capture that in sort of the like, yeah, are Minnesotans paying, less money when they go and fill a prescription sort of thing. So I recognize none of that really answered your your very basic question, but it's just kind of like my out loud thinking about that.
Right. I think our initial thinking on the PBMs, and I think you can see it reflected mostly in row 5, was really about like spread pricing and, but I think it's just sort of this question about like, there's this pie of money, right? And is it sort of, where is it going? So there's a profit taking thing, and it's not just affecting the overall cost of prescription drugs and health insurance premiums, but it's also, to your point, an access issue that then further downstream affects affordability if people are having complications from chronic diseases because they can't get their medications.
And I think it's maybe even, now that I'm thinking about this, I think maybe the way we can approach this to like get that closure aspect in there is even simpler, in that some of those same practices, the way rebates are done, spread pricing, are also like causing issues for local pharmacies in their efforts to stay open. And so it's sort of like they are kind of, one in the same. They're not only impacting consumers or patients, however we want to word that, which is reflected here, but they're also harming pharmacies. So it's maybe just like adding the word, pharmacy in there somewhere.
Yeah, or just thinking of it more broadly as a big bucket about fair pricing for pharmacies, right? And that includes the amount that gets paid, right? That comes out of, my pocket or my employer's pocket, but also fair payment to the person that's providing the service. Okay. Go ahead, Marie.
So I'm glad this has come up, because I just thought it was my default of years of bad practice of grouping things together to get more items into the priority list. Had a bad stint with the commissioner who did this all the time. But since other people are grouping, I find why at this kind of first pass in the process are we being so oddly specific on some of these things? I mean, there's like a topic area that we want to get to, because I was going to group 4, which is highly related to 12, which are both highlighted. And then, 23 way back at the end, which is hugely controversial, taxation policy. But if taxation policy isn't a tool in the toolkit, when you look at 4 and 12 in terms of how the marketplace is organized, then, I mean, still need it at least on the table. So, I mean, you could group them all together, but I'm just wondering if the buckets need to be just a little bit broader at this first pass point. So like pharmaceutical pricing and PBMs is a high priority issue for us. Kind of marketplace structure, including ownership and consolidation, is a huge issue for us at this point in time. I mean, there are a number of administrative issues. We don't have to go broadly, but we can identify some of them like prior authorization and credentialing. And I mean, some of the ones we've already identified, but so maybe there's a reason I can understand. I've been on the other side of that coin, why the drive to something very specific, because that's the only thing that's actionable for you all. But we're in a first pass kind of or not first, but an early pass kind of a stage that maybe regrouping these into a little bit bigger buckets. I don't know. I mean, you might actually need to sift out some of you might need smaller buckets, but
Yeah, I mean, I will say it was definitely a struggle, right? To figure out like what goes in which bucket, how narrow or broad are the buckets. And so what you're seeing is like the best attempts to represent it at this time. So you raised a question about the distinction between number 4 and number 12.
oh yeah, no, there is one, but
Oh, okay.
they're closely related.
They are.
And so and do we know at this point which is the better approach? I mean,
You could do both.
well, I know.
Yeah.
I mean, and but I would say that they need to be, because you don't know yet which one would be more fruitful or the way to go, or both. But yeah, yes, yeah, often that, yeah.
Right, although, can I ask for clarifying for MDH for number 4, is this strictly a transparency option, or does it actually involve regulation of health entity behavior?
Both,
Okay.
yeah. So, I mean, and again, these are all, the best conceptualization of, these are all sort of up for discussion as to how to capture them. I would say that I think of 4 and 12 as being different in the scale, I think, as to how, what kind of scale of the marketplace that we're talking about and what the options are that other states are trying. So I think of them slightly different, but I think that's a good discussion as to like, what else would we need to know in order to take forward some of these recommendations? That might be a question for us to come with a little bit more specificity. And to your point, Maria, on like how it feels like these are maybe artificially specific, given kind of the maturity of this group, right? And I appreciate that point very much, because I will say the way that we were originally started this exercise is to start to try to apply some of those factors for consideration, which you can't do on a super big bucket, right? You have to have something that's a little more specific, but we sort of stepped back away from those and said, let's kind of come back to this list first before we kind of really start to rigorously apply some factors for consideration. And so we still have this kind of oddly specific list as an illustration of that thinking, but appreciate that like what you're suggesting is maybe there's a bit of grouping. What I would urge us though to remember is this is informing what this group's agenda will be in August, September, October, November. And so like, how big of a bucket do you want it to be so that you can make some sort of headway and not have to like wait a year to get there, right? Because if you bucketed, I could imagine frankly, pharmacy as being a really long field of learning, right? And that's okay if this group wants to do it, but I just want to mean that as like a really big, that is a big bucket. So how do you want to think about prioritizing that?
Yeah. So, and also just as a reminder, like this is not the be all end all, like we're locked into this forever. We're trying to get a sense of like, where is their momentum? Where is their energy behind like, you know, ideas that we should pursue. It doesn't mean other ideas aren't valuable, but you know, often in processes like this, it's a really good idea to go with the sort of get that sense of like which things have the most sort of interest among the group as a way of prioritizing. So with that, I'm going to ask my colleague Henry Siegel to come off mute and kind of give us the instructions for how to do the poll.
Thanks, Shirley. So you all can use, so you have two options here. You can use your phones to scan the QR code here. That will basically enter you into Slido, which is a website that we're using the polling through. You can also go, if you're not able to scan the QR code, you can go to the website and then enter that code. It is going to ask you to enter your name. And so for those of you who are on the call, we just want to make sure that only the task force members are answering the poll. And we're asking you to choose up to 3 potential recommendations to prioritize.
Great. And so folks should go and like make their choices up to 3. And once that's finished, we will sort of share the screen with the polling results, correct? And
Yes.
Ellie's going to need to give me instructions. I need to like unshare the slides or something.
I have a question.
Yes, Sheila.
The poll that's in front of me has 6 choices
Yes, those are the 6 things that are
that are in
in
blue,
what's that?
that are in blue.
Nope,
Oh.
they're the 6 things that are in the non-value added spending bucket on table 1.
So this category.
The first 6.
Yeah.
Okay, thanks.
Sort of, you know, I would say like
I
consider
see.
the friendly amendment to sort of think about the PBM issue as like a fair pricing for drugs. I don't know that we edited the poll, but just think of it as like that's the discussion we just had. And when you're thinking about the priorities. And once we're done, we'd also love to get all your all's feedback on sort of how well this type of exercise works as a way of A, like how well the technology works, and B, like your reaction to using this kind of technique as a way of figuring out which ideas are most important to people. And I can see that people are still working. Oh, you can see the results. You can see them and we can't. Okay. Yeah, let's share them.
All right, Henry, I'm gonna stop.
Oh, this is my computer. You have to do that.
Ugh, this is hard. Okay. My gosh. Okay.
Is anyone still working? And hopefully, Jamie, you've had a chance to weigh in as well. Henry says we have 11 responses. Okay,
That's good.
Ellie says that's good. So it looks like this is helpful for us to understand kind of like as a group where your heads are at. It's a little hard to read, but you know, the options around investor ownership of healthcare entities is tied with the pharmacy option as we edited it for first place with prior authorization reform and low value care kind of in the tied for a distant second place. How does that feel to you all? Is that consistent with your sense of kind of like where the group is at and where you'd like to see us head with a more detailed discussion in May? Marie?
Yeah, I mean, I think with the caveat that the topic areas generally, like there might be different strategies around these topic areas. I mean, I don't know very much about PBMs and drug pricing and pharmacy access. That's obviously very complicated. So that in particular seems like it's going to change. And I think ownership consolidation, the market structure is another bucket that, I mean, if you're asking us to vote, would we rather have a transparency bill or a regulatory or like a transparency proposal or regulatory proposal? I'm hoping that is a future.
That's a future discussion. Yeah, absolutely. But as far as topic areas, it seems like the question is like, are you comfortable with this? Is there something from the other 4 ideas that aren't at the top that you feel like, gosh, it's really a mistake if we don't also pursue this in May and June? At least one thing, yeah.
Say, it looks like you have 2 that are separated from the rest. And
Yeah.
All probably have a point of 3, 4, 5, and 6.
Yeah. Well, that is super helpful. Alex, any reactions or?
Matt, I'll go to you first.
Sorry. My reaction is just that I think this is a useful exercise only because I'm really surprised at how much, to narrow it down to 2 that, as John said, sort of step out from the rest is, I'm a little surprised at. So I think that's great.
Well,
That's good feedback.
it's an accomplishment. Okay. So we are just 5 minutes from taking a break, but we do want to, and Ellie, I might need your help again to like reshare the slide deck. But we want to make sure we also give you a chance to tell us, okay, now we've got 2 things at the top of our list. Is there information you would like us to bring to you at the next meeting in May that's going to help us refine a little bit more? I'm also reminded, Olivia is not here today, but she had some really, I thought, insightful and specific comments about drug pricing at the last meeting that I certainly want to learn more about. I mean, and that is like, our proposals run the range from like specific to like, very broad and vague. And that was a very specific one, but it was definitely a topic that I wanted to learn more about. And so that's one thing that I think we will put on our list to see if she's available to help us learn more about that. And then what else do you need to sort of just continue refining this work, moving toward hopefully having a set of initial recommendations in June, remembering that the recommendation can be to learn more about something or study something. It is not a recommendation to the legislature to do something specific. It could be, but it does not need to be. Marie.
Well, we've talked a lot about marketplace consolidation and ownership changes, and we really haven't gotten information about the like details on that trend, and nor the work that the AG is proposing now. That would be really helpful to understand. I mean, some of the recent work they've done, and then I understand there's something new afoot, and maybe not just trends in Minnesota, but nationally. I think some of the national silliness is coming to Minnesota too. So it'd be nice to know what that's going to look like.
Okay, can you just give me a little hint more about what you mean, like the national silliness?
Well, just the drive to, I mean, we've had a largely nonprofit based system, a lot more investment ownership, a lot more splitting out of profitable service lines to investor owned types of things, leaving hospitals less likely to shift around costs and, stay afloat. That's
okay. Thank you.
silliness to which I refer at the moment.
I would add a current topic of a owner or a partner, cross-state partnerships, I guess I would say. So Sutter
Okay.
from California coming to be the partner or acquire, or whatever word is politically correct, of Alina is an example of what I think we should understand, the impact of, not just for this, but it's happening all over the country, so we can learn from others.
Okay. Philip,
I was glad somebody else already said the same thing, that they don't really understand drug pricing and PBMs. So that's true for me too. So I feel like in order to have anything useful to potentially say about it, I'll need like a pretty basic, like, introduction to how it works first. Thanks.
Super simple.
One meeting, no problem.
I assume working with Olivia, putting into the buckets of what we're talking about, because again, these categories are broad, so we're talking about spread pricing, or what aspect are we talking about? Educate us on what those are and the impact on affordability that each of them have.
okay.
And maybe to understand from the experts on our committee or a task force, what is the problem we're trying to solve? Like, what is this group supposed to be focusing on? Because there are lots and lots of smart people out there already working on pharmacy pricing and PBM. So I too need a 101 on it, but to what end?
Yeah.
What am I getting myself educated to comment on or recommend or understand?
Perfect. Anyone else want to jump in before we take a 10-minute break? Andrew. Oh, Adam.
Yeah, I think to that point, and you could probably put this on administrative waste or any of these other pieces. I think the highlighting of, the profits, the extraction, like whatever, the money going to $4.3 million salary, like whatever whatever information can be shared on that as well. Because we've mentioned a lot of things about, well, is it worth the squeeze, all this, if we really want to talk about like, what are we going to call out and try to affect? And, you look at some of these options of taxation and all these different things. And if we don't at some point recognize the both extraction tax, the whatever you want to call it, to lead to somebody else profiting and taking money out of the system for their own gain, and the small group of folks that are doing it, then we're going to continue to be like sloshing around ideas that, just nibble around the edges. So anything that can identify those as well, that would be great.
Okay, so I think just to give a little preview of kind of like how we'll think about these two issues moving forward is, we're likely to think about them using these factors for consideration that Alex already talked about. And so like your comment, Adam, about like, well, what's the impact of various things made me think about that. So that's kind of the next step, is to take these two things and try to break them apart a little bit more into some of the pieces, as well as how to think about the factors that we've talked about. All right, with that, let's take a 10-minute break, and we'll come back and sort of have a similar discussion about prices.
Exactly.
I keep doing this.
I know.
Like, I'm not going anywhere.
You're not going anywhere. That will not move. Yeah.
You show me how you do it, then I'll know how to undo it later. folks who are online hear us? Maybe Henry or Jessica, let us know if you can hear us.
Yep, I can
Okay,
hear you.
great.
Yes.
All right, we're just getting started.
Mic check, mic check. Mic check.
All right, so we're still missing several people, so give us a couple more minutes.
Yeah.
All right, if everyone could take their seats, I think we'll get started. So now that we've sort of been through this exercise once, I'm going to do a lot less explanation the second time. But our sort of second exercise that we wanted to lead you through today is just like the last one, except that it is about prioritizing ideas related to high and variable prices, which you will notice that the things on the list are all things that have come up in previous task force meeting. Just as a quick overview, so one of the items is developing options to strengthen our health insurance regulatory processes. And, you know, there's a number of things that could include, including, you know, setting benchmarks for provider reimbursement growth, price variation for services, a whole lot of things in that bucket. And we're not asking you today to tell us which things in that bucket. We're asking you to tell us how important is that bucket relative to other things. The second one is developing options for establishing a healthcare cost growth target program for the state, including, you know, what would that look like? You know, who's accountable? What would public reporting look like? All of the details of that would be a subject for another day. The third item in the bucket is developing options to directly reduce prices or directly reduce price growth. So you can think about a situation where you don't, you know, if you only regulate price growth, then you're accepting the fact that prices are pretty high today, as opposed to you want to reduce the prices themselves and then limit growth in the future. Developing options to strengthen Minnesota's oversight of consolidation in the market. So this, again, this is sort of like that enhanced review of mergers and acquisitions. We've had a little bit of conversation already about that in the discussion on in the discussion on the non-value added spending bucket. The other four items that are sort of up for discussion right now on high and variable prices are establishing Minnesota-specific price benchmarks for a given set of services to just sort of, it's a little bit more of a transparency exercise to say, you know, this is what fair prices are, but it doesn't go as far as actually regulating those prices necessarily. Alex, tell me if I'm getting this wrong. Assessing options for establishing consumer affordability standards. So this isn't regulating prices, but this is establishing a framework that says this is what we think is reasonable to expect a consumer to pay out of pocket for premiums and or cost sharing. You know, when I think about an example of an affordability framework, I think about the the premium subsidy schedule that exists in the Affordable Care Act that says, okay, at this income level, we only expect you to spend 2.5% of your income on premiums. So something like that is what this option reflects. Identifying opportunities and strategies to improve healthcare price transparency specifically. And then looking at facility fee regulation. So this would be like limiting the circumstances in which it is allowable to charge a facility fee, for example. And we had some discussion of that at our last meeting. I think somebody brought up an example of actually a facility that like was an urgent care for part of the day, an emergency department for part of the day, and people could never know if they were going to get charged a facility fee or not. So those are the 8 ideas. Let me turn to Alex for some commentary on the ideas, as well as which ones are shaded in blue on the table. And then again, I'll turn to Matt and we'll open up to the group for discussion.
Okay, so you will notice, we changed up the mics a little bit. There's a lot more options here, and that again is reflective of what we heard from this group. And it's also reflective of the fact that there are many different examples around the nation right now of states taking action on this issue of high and variable prices in the commercial market specifically. And so just naming that this is a little bit of a different exercise, even though there also is some relationships with some of the other issues that we just talked about, like ownership, for example, ownership of different healthcare entities. I want to note number 7 and number 8. Those are 2 of the blue highlighted items, and those are listed on the things for potential consideration as a direction that we've heard from this group. And I would say a couple of these, including 7 and 8, but also including number 10 and number 9, number 10. These are all what I would capture as like what I have heard from this group, what we have heard from this group as naming affordability standards, or naming like what is an affordable healthcare system in Minnesota? What is the vision that we have for a more affordable system? how would we know that we have reached that? And so these reflect back to you, I hope, some of the conversations that we've had about that. So for example, number 7 and 8, number 7 is this discussion of a cost growth target, which is a very specific type of program, but the essence of it is to say, how much should healthcare spending grow every year? How much is it growing in Minnesota? And to what extent is it appropriate, growing appropriately? I will say that as we look across at like the 8 or so other states around the nation that have healthcare cost growth targets, they are not meeting those targets, right? They are not seeing savings accrue to consumers. And so I sort of see this on the list and I reflect back to this group. Is it worth having this group have a really sort of focused discussion of like, how much should healthcare spending grow as kind of an organizing framework for talking about what an affordable system would look like, even if kind of this specific idea of a cost growth target isn't gonna like be the one and done solution to improve affordability for consumers. So that's just one example of like how you might imagine some of these examples of 7, 8, 9, 10. Those are affordability standard ideas of like being perhaps organizing frameworks for this group to think about what is an affordable system. I'll name number 8 as another example of one of these like affordability kind of defining framework ideas, as being basically a re-looking at our health insurance regulatory review, a rate review process. We have had some discussions so far with Commerce, which is our regulatory authority in Minnesota, and there is interest to look at our current rate review processes and see if there are ways to strengthen that from a consumer affordability standpoint. And so I just name that because like that's another example of why this is raising up for us as like a blue highlighted option for this group to consider. Number 9 and number 10 also sort of worthy for discussion, other ways in which you might think about what is an affordable standard, but they just didn't sort of rise to the top as like things that this group has repeatedly come back to and said, hey, can we have a definition of like, what is an affordable system in terms of, let's say, out-of-pocket spending out of your median income? Like if that's worthy of discussion, I want to hear that today. I'll say just one other thing about the fact that there's just a lot of sort of price cap and price growth and, there's a lot of different sort of jargony terms in here. This may be a good place for this group to say, I want to bucket these bigger. And so they may be too specific for us to really like reflect on today. And I want to open that up for discussion. Matt, what would you add?
I think the other thing, one, based on my optimism from our first poll or survey, is encouraging people, at least one of the things that I'm hoping to get from this next exercise is, as I look at these options, is a little bit of a split between, do we want to pursue recommendations that make information available? We're gonna make prices more transparent. We're gonna put out information about here's what's should be an affordable standard or whatever. Or do we want to pursue recommendations, or do we want to take direction on ways where we're actually looking to regulate the market or actively shape the market? So, price caps or growth caps or something like that. Because I think I think that is one way of seeing these and getting a sense from this group about what are you sort of how aggressive do you want to be in the kind of policies that we're gonna be developing. Does that make sense? I felt like I was really inarticulate at a point there.
Great. Sheila?
Yes, to you, Matt. The answer is yes. So if we're going to if we're going to lump these, they really do fall into two major buckets. And it is hard to parse out the specifics of each of these because you just highlighted that 8 other states are doing price caps, I think is what you said, cost growth targets, and they're not working. So yes, I want to talk about price transparency, but do I want to cast a vote for something that already isn't working in 8 other places, as an example? And so, and then you mentioned there's an appetite for relooking at the health insurance regulatory process. Well, if that's already in motion, what value is there for our group to, do you need us to jump on that train, or do you need something different from us that isn't already being discussed? Or could we just say yes to more transparency and yes to more regulation, and then we'll parse out those two major categories as we do our work?
Can I just comment on this? Because I think it's an important point as to like how we organize. Is it putting out information, or is it kind of, pursuing regulation? And I continue to come back to what is this group's unique value, this public space in which we have time and assets, research assets and analytic tools that we can bring to this group and shed some really, clear, hopefully, light on like what is driving high healthcare spending and what are other states trying and what might Minnesota try. And so I wonder if it is also helpful to think about these as what do other entities, if they are going to use the information coming out of this group, need in order to carry forward some of the recommendations that this group might make? So for example, on the cost growth target idea, maybe realistically, I'm looking at Stefan, it could take a couple of years to really get to a place where we have a really clear understanding of like, what is the target? For Minnesota to really lay out a program that looks like one of these other states who have created a program like that, it might take a couple of years. But maybe a question for this group is it worth having a conversation that is conceptual first? Or is it worth saying, actually, we really need to be like focusing on the regulation and what others are working on in terms of, price caps and that sort of thing? And so what I see is there is some value in this group really putting out information, like putting out clear reporting that doesn't exist anywhere else in the state as to how much we are spending, what do we know about the drivers, what are the options for Minnesota? And so so I might just characterize the putting out information as being actually still quite valuable because it doesn't exist anywhere else. And that's what I have heard from Commerce. That's what I've heard from other entities that would use some of the information that this group would put out.
And I will also just add, Sheila, to your comment about sort of like the cost growth targets. Like, I don't think we're saying today we're interested in establishing cost growth targets. Like, because you might say, well, I'm actually interested in the idea, but I want to understand more about why aren't they working in other states and what could be different. So it is not the same as like endorsing the idea, but it's saying this is an idea that we need to explore more. Marie.
Yeah, I mean, my comment about, it seems like we've jumped to specificity. I mean, we've jumped to a level of specificity I'm not even comfortable with here, which does not mean I'm not supportive of it, but like, not only did 8 different states have growth targets, Minnesota had cost growth targets, but more recently than that, Minnesota repealed cost growth targets. So, you know, so what would we say about what has changed now that we think it's a good idea when it was not that long ago? It was a not supported idea, at least. So I'm not comfortable that we've gone, like we are to the point where I think I could get to what Matt said, you know, do we want to kind of give it a sense of the group? Are we leaning more toward a regulatory path or a transparency path, and which for what? But this level, there's some really hairy stuff in here. And I don't know that I mean, we should really understand the consequences. Even I've been uncomfortable with high and variable prices as a tagline for this. High prices, sure, but then we'd have to discuss that we don't think that there's a reason for price variation in healthcare. Now, maybe that's true because we have a uniform product and there's nothing about the convenience or quality or access of something that we'd be willing to pay a higher price for. But we haven't had that conversation. So high prices, yeah, maybe there's a reason, you know, things should be less. And maybe there should be benchmarks out there and reference points. Sure. We've like jumped into a level of detail that and the hornet's nests that are in here, I'm perfectly willing to kick them. You know, I've been stung a number of times, but I think we should all be aware of how big that hornet's nest, and is it, you know, honeybees or killer wasps that we're going to kick open here. So
Right.
I
And
just think
yes, and there's plenty of hornets nests in the last topic we talked about too.
yeah, but I think we stayed at a level of generality. At least I felt like maybe I just in my own mind did the bucketing thing that we needed to do to provide the space to like take it up a level about, hey, we're looking at this transparency around these. Yes, I don't think anybody's really excited to have us looking at their business relationships. That's a hornet's nest, sure. But I don't know, this one feels particularly more specific and a lot more gnarly to me. I mean, and I can't answer the question, what has changed since Minnesota last repealed their cost growth targets that I believe that the state is right, the time is right for them now. I can't answer that question.
I want to jump in and advocate for variable prices.
That we shouldn't have price variation?
Yeah, that if hospital A is paid $15,000 for a hip replacement from Blue Cross Gold Plan and $12,000 for the same hip replacement for the Blue Cross Plus Plan and $7,000 for the same hip replacement from the Blue Cross Bluebity Blue Plan, that variation is unreasonable and it doesn't make sense. And so there's variation in payments for the same thing to the same place that is not economically justified. And there's savings there that could be made to say one service, one price. If your hospital is offering this service to this health plan, that health plan is going to pay one price for it. We're not going to have 8 different pricing models. When you look at the price transparency that's been available from hospitals and from some health plans, both of which pox on both their houses for not complying with the federal rules. So I'm not, but when you look at those, it is nonsensical.
Absolutely.
Yeah.
I don't disagree. I mean, there's some price variation that's insane. We should just be aware though, that the cost is going to get shifted somewhere. So let's think about where they're going to do it. Because right now we'll have uniform pricing, but there'll be some other absurdity that happens. That's totally fine. I get that. I'm not, but not all, whereas all high prices are probably bad, not all variable prices are bad. There are reasons for price variation. I know what you're saying, but yeah, I get, yeah, we should say high and insane variation in pricing. Stupid. Yeah, exactly. Stupid. the whole category.
John, did you want to jump in?
Well, I'm just curious how table two is fitting into this. I think they're.
Good question. Yep. So like the two items in table two, that are part of the high and variable prices bucket are items 19 and 20. So I would say like along this lines of like transparency versus regulation that we're talking about right now. 19 is more of a transparency one, right? Just look at the drivers of commercial price variation. And 20 is a little bit more of a regulatory one. I will also note, since we haven't talked about it up to now, that there are 6 more ideas on table 2 that we are not sort of asking you all to weigh in on today, but they are things that came forward in the brainstorming exercise that we don't want to lose track of. But if you want to make an argument that they belong in one of these buckets or like that they are a priority to pursue in May, now is your time.
The insurance, the high risk pool that we used to have in the state was awesome, and they're really expensive. We have a methodology to fund that, take them out of the pool. And then it would be a more affordable insurance for everybody, ACA or whatever we decide to apply that. High risk pool too. So again, it's 25. It's just one. We all have different backgrounds and things we're looking at. I just want to put that back on the table that it's from affordability standpoint. Somebody should be looking at this. And I don't know if not, that's going to.
Okay, so that would potentially fit in as like an insurance regulatory framework type of idea. What do others, well, like any other, but I think I would like to call a question of whether we want to include that one in the poll before we get to the time of doing the poll. But Sheila.
No, we can talk about that first.
What do you all think? Does it belong in that? Does it belong as part of the options that we're ranking today related to pricing?
I mean, why can't we include it again? Why don't we bucket it in? If we're gonna strengthen the health insurance, I don't know if I'd call it regulatory process, but certainly the discussion of a high risk pool should be in there somewhere. That seems.
So would you think, let's fold it into that item that's already there, or John, did you want to see it as a separate item?
Which I.
It is.
Number 8.
Yeah, number 8.
And Julie, just for benefit of like similar to the question that Sheila asked about, hey, we're using this term value in 3 different ways. Like, can you just talk a little bit more? I know we talked last time about just what is a high risk pool, and like we already have a reinsurance program, for example, in Minnesota. Like just maybe just a quick primer on like what is this idea?
Sure, I can start and then John can jump
Sure.
in and correct me if I'm wrong. But I think you're talking about the old high risk pool, right? The pre-ACA one. So in Minnesota, prior to 2014, you could be turned down to buy individual insurance coverage. But if you were, that made you eligible to buy health insurance through an organization called the Minnesota Comprehensive Health Association, or MCHA. And the premiums there were a little bit higher, like they were capped at 125% of the regular market, which was like pretty good if you were like not in good health. And that was funded. So you had most of your really expensive people in that high risk pool because if they would apply for individual coverage and get rejected and be in this pool. That pool was funded by an assessment on all the health insurance companies that do business in Minnesota. So it was a way of ensuring that people could get coverage. It's different than the current framework, and a way of ensuring that the burden of paying for the high costs of people who couldn't get coverage was spread. Not only today, it's spread across the individual market only, which is not that large a share of Minnesota's population, but it was spread across the entire, really just the fully insured market. So, but a much larger base than previously. So John, what would you add to that?
wife has a condition and health insurance. These people are, should they be in a broader pool by this, some funding through the state while they have more insurance within stuff that happens. So your concept is absolutely right. I don't know what the answer is. I don't know which pool. Just something that if you want to think about affordable, manage this group differently and as a provider to help fund.
Yeah, what I'm less current on is, so like the ACA came into place, you can't be turned down for coverage. But what that effectively means, unless you've done something else, is that the cost of the high-risk people are all contained within the individual market, which raises premiums a lot in that market. I don't know that much about like the reinsurance stuff that we have in place now, but that mitigates it to some degree.
Yeah.
Yeah.
Is a mechanism. Make it affordability for a certain group of. A lot of stuff we're talking about is about system-wide effects, everybody. This would be a solution that we would find with the population, would make it more affordable to have access to healthcare.
Yeah, and I'll just add that that was one of the reasons that it didn't merge into the table one, because it was kind of not matching what this group was asking for in terms of like transformational change. But there may be a very good reason to move it up. So, Philip.
One second. So just to that comment, I want to understand then, why are there more $1 million patients? And that does, I think, speak to a bigger systemic problem, that it's not just trying to solve for that group, but why is that group getting bigger? What are the cost influences? What are the behavior influences, et cetera? So that then speaks back to this low value, overuse, et cetera. So I think it is a systemic question. Yeah. Right.
It's causing high cost people.
Right. So it does, I think it does fit into the bigger picture question. That's not what I was going to say. So still have the mic 1 more second, which is, I'm sorry to get so hung up on semantics today. Maybe I do all the time, but I think one of the things I'm tripping on here is that all the verbs are different. And it speaks back to what we're trying, what are we supposed to be doing? So are we developing and establishing new policies, new recommendations, new tools, new levers, or are we just crunching the numbers to estimate and analyze and assess, or are we digging into things to better understand them, evaluate, et cetera, and then to what end? So some of these are very action oriented, and some of them are more, oh, we're just going to ponder the universe and try to get a better handle on X. And I'm still not clear on, maybe it's all of the above, but I think this is like a 4-dimensional jigsaw puzzle here, this table is, so I just added a 4th dimension. I apologize, but which are we doing stuff, or are we just trying to better understand stuff so that the Department of Health can do stuff, or the legislature can? Who are we serving?
And do you think that's the same or different from Matt's point about transparency versus regulation?
I think it's a subset of that. So yes, I support, I like the clarity of transparency and regulation as 2 big buckets, but underneath that, so let's say we say we're gonna land on regulation as the sweet spot for this group. Are we developing new policies? Are we identifying what works out in the universe? Are we just trying to better understand it? Are we trying to estimate it? Like, what is our role within that bucket?
Right. And I think the answer to that is it's TBD, right? Like, we have to get further down the path before we understand that. But today it is, what are we most interested in? But Philip, go ahead.
Two things. One, on the suggestion about moving number 20, I am fine with voting it, but I now thank you for the trip down memory lane on MCHA and the history. I don't think it fits in number 8, because I think that that's a category that's about changes to the regulation. And just from your explanation, I think that's a different kind of tool that would change pricing. And then a process suggestion, just because of all the discussion about the sort of big picture question of transparency versus regulation. and then all of these more specific items. I wonder if we could use the same polling exercise as you've designed on these more specific items, and then have a separate question, which is if you had to choose preference between those two to get a sort of sense of direction on that as well.
We could potentially do that. I think we could check with Henry to see if that is something he could do on the fly. But I think what I'm hearing is more of a consensus toward pulling number 25 as an additional polling option than combining it with something else. Okay. Justin.
Yeah, I was just, this isn't to discount, I think, the sort of discussions around categorization that have been brought up that I think are really valuable. But I was just gonna, I guess from this list, 11 and 12 are sort of two items that stand out to me. I think on prices, you know, to continue, we've been talking about Sutter a little bit today. You know, the antitrust lawsuit against them in California found prices in Northern California were 70% higher than in Southern California, and sort of linked that to Sutter's dominance in the market. And certainly prohibiting additional consolidation is one tool there, but we also have the reality that, you know, here in Minnesota, we have plenty of markets where there's already an immense amount of consolidation, and absent someone starting to pull health systems apart, which I don't think is going to happen. I think sort of having a conversation about how do we address those prices, and that pricing power is important, which I think is it's sort of captured in 11, or at least my understanding of 11. And then I think on 12, just I think one maybe, you know, there's been some work done. We had a really important law passed in 2023 on healthcare mergers. But I think, you know, at least one thing I'm sort of curious about, and maybe falls in the bucket of tools to increase competition, is there's federal legislation that's recently been proposed that would sort of deal with vertical integration in the healthcare system. And I think exploring, like, are there components of that a state could, you know, utilize, would be an interesting question. So yeah, just kind of my pitch for 11 and 12.
Okay, thank you. Anyone else? Marie.
I don't want to ignore the point that Philip brought up about getting a sense of the group on kind of a transparency focus and a regulatory focus. I hesitate, though, to pit them against each other. But to me, it speaks to that lack of that broader vision and that big audacious thing we're going for, which I suspect if we fleshed it out would contain a little bit of both, that we would want a healthcare system that had a lot more transparency and sprinkled with some regulations to have it make a little more sense so that consumers could find it more affordable. So I hate to pick between them, like pit them against each other right now. I think if we had the audacious vision, it would contain elements of both things. And I think we should go for that broader thing.
It's certainly not one or the other. Do you all think there's value in sort of just taking the temperature of the group, sort of like are you leaning more towards, you know, regulatory versus transparency? I mean, if we do that poll, right, we're going to make you pick one of two things. We're not going to let you vote for both. So the question is there value in doing that? And you're saying
value for you?
not necessarily.
I don't.
You know, I think that we'll probably get a little bit of a sense of it when we do the poll, which we will do in just a couple of minutes, to sort of see, like, you know, what are the top things? And if we see transparency related things and regulatory related things there, then I think in a way we have our answer. But I guess we'll know when we get there. Andrew. Oh, sorry, Marie.
No,
I know we mentioned about price variation 19. Does that fit in something else? Well, to me, I'd like to know what's the reason for the price variation before making kind of policy. Right, so.
And I'll be honest that I feel like 19 is really, one of the reasons it only landed on table two and not table one is because it's kind of implicit, like we would have to do a lot of that kind of investigation in order to do any of the work here, and we're already doing some of it. So we wanted to include it because it was reflective of, again, what the discussion that we had before in February, but it's kind of implicit in some of these other ones. So thanks for pointing it out.
I'm looking to see like which thing we could just, if you want to try to make it explicit, like which one we could add it to. Maybe the most logical place would be like 13, since that's well, it's transparency, but I feel like that's also just like understanding of the, it's more descriptive than it is regulatory or policy.
Yeah, I think of it as under 11.
Under 11.
Mhm.
That's like the first step. Okay, the first step to 11. Okay, so you want to say it's implicit in 11, number 19.
That's what I was saying.
So if you're a big fan of 19, vote for 11.
That's a trick.
Okay, any other
Can I
last
just-
comments
I'll just-
before we actually try to do the polling?
I'm not lobbying for this to be anything that pops onto the front page, but I am a little bit alarmed. And 22, that the impact of AI is just kind of one of those demographic futures into the future. I mean, we talked about skating to where the puck's going to be. If we don't pay attention, we're going to find ourselves on a whole other sheet of ice, not even playing in the game. So I don't know how we do it. It doesn't, there's not a specific recommendation for it, but if we are not considering the impacts to cost and access that AI is happening, and will exponentially begin to have, then we're just a lot of this is just gonna be backward looking nonsense, so.
To help advance that idea, could we just make it a rule that wherever we land, AI is always on the table? Its influence on any of the topics that we're looking at. And let's not forget about it because it's listed down here in number 22, but it should be embedded or assumed in every single one.
Yes, I think they're all embedded in, like, yes, the realities of today and where we know the systems are heading, and we need to be thinking about that as we continue our conversation about priorities. All right, any last, if not, I think we can do the second poll. Like, just as a reminder, the poll is only for task force members. And I think Henry is going to share the screen. Hopefully we've added number 25 as an option to the poll. Oh, yeah. And then Ellie needs to help me with the technology so that we can show the results to you. And Henry, maybe if you could let us know when when it seems like everyone has weighed in, that would be
I can't
helpful.
open mine up. It's like shutting down on me for some reason.
So waiting on 3 people.
I can't open it up.
Is it possible for one of us, if we've voted already, to
Right.
like reset? I
wait,
tried, oh,
Hold on, it's going, I don't know why, it's so slow. Okay,
there we go.
now I'm gonna- all
I
right,
think.
sorry about that.
Okay, so how many responses do we have so far?
We have 8 out of 10.
Okay, so give you all a couple more minutes. Did it work for you, Marie?
Yep. got it.
Okay.
Thank you. Thank you, thank you.
All right. So it looks like, Henry, I'm not sure if, like, we're scrolled all the way up now, right? Like number 12 is the top most popular row. Okay.
Yes.
Yes. Okay. Market consolidation, is the top priority. Insurance regulation is second. Sorry, the third one is about, commercial prices and price growth. And then if we scroll down a little bit more, just to see how some of the other options did. Yeah, so pretty clear cutoff after number 8, which got 50% of people, and then there was just more variation. So how do we feel about that?
I don't know much about insurance regulation, but do number 11, if we did number, sorry, 8, would we get to number 11?
Not necessarily. Because number 8 is aimed at health plans and number 11 is more aimed at provider prices. I mean,
Oh,
part of number 8 could be regulating the prices that insurers can pay, but it would not necessarily be.
so one is provider and one is payer, are you saying?
Yep.
I mean, yes, Sheila, we can talk more, but I think under number 8, yes, those are health plans who are submitting data to Commerce, to our regulatory authority. But Commerce does have authority to review contracts between health plans and providers and to review those contracts and say, what are you paying as an appropriate payment? And potentially offer benchmarks that say that's too much. You shouldn't allow that payment, right? So in other words, I wouldn't quite designate them as like plans versus provider caps, and rather that it's just the mechanism through which you might implement that.
You ready to
Yep.
take it back? Okay.
Yeah.
Yes, and so just like we did with the other discussion, sort of the next question is, okay, so now we've got 3 things that seem to have the interest in energy and momentum of most of the group. What else do you need to know about those things in order to continue making progress toward developing a set of recommendations?
I'd like to hear from somebody at Commerce about what regulations they're thinking that we might be able to, and the impact that would have on consumer affordability. I mean, the fully insured market is such a small sliver of the market. It's an important one, but it's not a very big one. So what do they think could be done, and what would the impact of that be?
Great. What else? Philip?
Thank you. I think it's captured in number 20 on the second page, is looking at experiences from other states. That seems like in particular for me anyway, for sorry, which number? For number 11, that would be helpful to get kind of a report on what other states have done and impacts.
Else have things that they want us to bring to you? Justin?
I think on number 12 in addition to what I mentioned earlier on vertical integration, I think it could also potentially be helpful, maybe similar to Philip's recommendation, to sort of look at the law we have in Minnesota from 2023, but compare that to what other states have in terms of their merger review and approval and that sort of thing, to kind of set a benchmark for where that law is at. And then maybe also just a general sense from the AG's office of like how they've used it or that kind of thing if possible. So.
Okay. Anyone else? Well, I hope this has been a helpful way to sort of figure out kind of like where our energy is as a group and what we should prioritize. Talking about moving forward, I'm going to turn it back over to Alex to close us out.
Thank you all. Really helpful conversation. I know we're like in the weeds and also sort of zooming out. I'm just appreciating this group's curiosity and openness to kind of trying this exercise out with us, recognizing this is not going to be the last time we get to do it. So thank you. And a couple things coming up. One, we have our next meeting booked here on May 14th, 1 to 4 p.m. And I did mention earlier today, we'll be in touch with you about that May 20th conversation, 1 o'clock. That's a virtual conversation. We've asked a couple of folks to help us recruit and just think planning. We've about sort of the purpose and what's going to be most helpful for this group. But the intent of that is really to reach out to consumer advocates and groups working on healthcare affordability to just align and think about how we can sort of offer some value into that field. And then, of course, the Provider and Payer Advisory Task Force will come together next in June. And so this group's coming together twice, and that's on purpose to really like get some momentum around like what are the directions we want to be offering. And we will also be thinking about ways that maybe we want to get some additional input from, and I'm pointing at our two Provider and Payer Advisory Task Force members in the back, may want to get some additional directionality or like kind of direction in between those meetings, since that's a bit of a gap. So just be thinking about that, and we may reach out to you all to get some guidance on that. Thank you for the afternoon meeting on a beautiful day. I hope you go enjoy some sunshine. Take care. Thank you for folks online for sticking with us.